Good evening and welcome. Thank you so much for joining us for tonight's webinar, Cannabis and Tourette Syndrome, the Evidence, the Promise, and the Perils, presented by Dr. Elia Abi-Jaoude. Hopefully I don't butcher that. My name is Katie Delaney, and I'm the Family and Medical Outreach Coordinator for the New Jersey Center for Tourette Syndrome and Associated Disorders. I will be your facilitator for this evening. Before I introduce our presenter, I want to go over some housekeeping notes. The audience is muted. If you are attending the live webinar, questions can be submitted in the questions box at the bottom of your screen. During the live Q&A, the audience will gain access to unmute themselves. We will stop recording right before this. At the top right of your screen, you'll see a paperclip icon. At the top right of your screen, you'll see a paperclip icon. There you will find a copy of the slides and upcoming events. At the bottom of your screen, you'll see a React button. To the right of it is an arrow. When you click the arrow, you will see a few emojis appear, such as a heart, a thumbs up, etc. Throughout the webinar, feel free to use this feature to let our presenter know how they're doing. Give me a thumbs up, you guys, if this sounds good. Beautiful. Thank you. Thank you. Okay. So for those viewing the webinar recording, you will not have access to these features. However, any questions you have for the presenter can be submitted through the chat box to the left of your screen. The presenter will answer those questions on our webinar blog located on our website, njcts.org, under the Programs tab. This blog will be monitored until Tuesday, February 4th. Any personal information will not be included in the post. Real quick, for the Q&A section for the live, in addition to the audience gaining access to be able to verbally ask their questions, also feel free to manually submit questions in the questions box in the upper right hand of your screen. It'll be a box with a question mark in it. So we'll be answering those as well. The New Jersey Center for Tourette Syndrome and Associated Disorders, its directors and employees assume no responsibility for the accuracy, completeness, objectivity, or usefulness of the information presented on our site. We do not endorse any recommendation or opinion made by any member or physician, nor do we advocate any treatment. You are responsible for your own medical decisions. Now, it is my pleasure to introduce our speaker for this evening, Dr. Elia Abi-Jaoude. How did I do? Good, awesome. Dr. Abi-Jaoude is the medical director of Ambulatory Psychiatry at Toronto's Hospital for Sick Children, where he leads the Provincial Pediatric, Tics, and Tourette Clinic. I'm struggling with these words today. He holds an MS in neuroscience from McGill University in Montreal, an MD from the University of Manitoba, and a PhD in Cognitive Neuroscience from the University of Toronto. Dr. Abi-Jaoude also works at the Tourette Syndrome Neurodevelopmental Clinic at Toronto Western Hospital. Oh my goodness, specializing in developmental neuropsychiatry. His research spans neurobiology, psychopharmacology, cannabinoids, and function-like tic behaviors. Oh my gosh, that is a mouthful. I love it though. So, Dr. Abi-Jaoude, the floor is all yours. Ooh, you are currently muted.
All right, can people hear me now? All
You are
right.
all good.
Okay, and can people see this in presentation mode? My slides? Can I get either a thumbs up or a yay from you, Katie?
Yep, we're getting a whole bunch of thumbs up. You're good to go.
Okay, great, perfect. All right, well, thank you very much, Katie, Brianna, for this invitation. And I would like to acknowledge and thank the New Jersey Center for Tourette Syndrome for the opportunity to present to you about this topic. And thank you all for being here to listen to this and allow me to share some of my experiences with this on this I think a very exciting topic. And I want to thank my collaborators and colleagues that we've worked together for over 15 years now in this area. And I especially want to thank the patients. This has very much been a patient-driven endeavor. As you'll see when I get into more details about it, I got into this because patients talking about it, and first clinically, then and then subsequently we've done some research on it. I do think cannabis is promising, but I think we have to be cautious. Okay, as you'll see as I go through this, that the quality of the evidence is variable, and the whole thing is very new. Okay, so again, this is something we have to be very careful about. And in recent years, there's been an explosion of interest, and particularly in cannabis, for all sorts of things. And again, I think we have to be careful. Um, any new treatments, there's a famous quote from William Osler, who's considered the father of modern medicine. And he says, when a new drug comes out, you should use it as fast as you can before it stops working. And what he's referring to here is that when something first comes out, we're all excited. It seems like a panacea. It works for everything. And then it's only a matter of time before we realize, well, it's not so perfect and maybe not a great idea at all. So anyhow, while I do think that cannabis is promising, I think we have to be cautious. And without further ado, I'm going to get into things. And I'm going to speak a little bit fast just because I have a lot to share that I want to share, and I want to make sure that there's a good amount of time for Q&A, but hopefully not too fast. And if it is too fast, I'm happy to slow down. I could even skip over stuff. Not everything has to be covered in like excruciating detail, but
We'll keep you posted on the speed.
perfect. Thank you. Thank you. All right. I have no financial conflicts of interest to declare. And the other thing is I'm going to use this into laser pointer. Okay. So in terms of our objectives for today, what I'm hoping is by the end of this session that you'll be able to describe the current evidence for cannabinoids in the management of tics. Okay. And evidence, you'll see there are different kinds of evidence, and what the results are will differ depending on the type of evidence we're talking about. So we're going to go over this. The other thing I want to point out is I use here the term cannabinoids. Okay, so cannabinoids is a term that includes cannabis, which is the plant, the herb, but it includes other things, pharmaceuticals that work on the cannabinoid system in the brain. Okay, so it's kind of a very general term. So we're going to talk about the evidence for cannabinoids in the management of tics. You will know when to consider cannabinoids in the management of tics for adults with Tourette syndrome. You'll be able to describe the potential benefits and harms of cannabinoids, okay? So a lot of the times we're focusing on the benefits and we forget about the harms. It's not just for cannabinoids, it's for all of our treatments, okay? And this is something not to forget, this part of the equation. And then lastly, um, I'm going to touch on practicalities around administration of cannabis, okay? And here specifically cannabis, it has its own kind of complexities when it comes to how do you administer it, and we're going to go over that, okay? All right, so first, just kind of the first couple of slides are going to be kind of more introduction to Tourette syndrome kind of slides. It's really just one overview slide and then one just on medications for Tourette syndrome, just to make sure everyone's on the same page. Just quick summary. What do we do for Tourette syndrome? So first of all, Tourette syndrome is a condition defined by motor and phonic tics. That's what characterizes it, but the majority, as we know, have comorbidities as well. But that's what defines Tourette syndrome. There's a typical course that tics tend to follow. They tend to start early childhood, and then even as they fluctuate, they tend to peak around early puberty, so around ages 10 to 12. And then for most people, there's a gradual decrease thereafter, um, such that by early adulthood, the large majority outgrow their tics, but not everyone. Okay, a good quarter, roughly give or take, do not outgrow their tics and continue to have significant tics as adults. What do we do in terms of managing Tourette syndrome? For a lot of patients, well, for everyone, education and reassurance and talking about what tics are and aren't and what to do and what not to do is a big part of what we do. And I put this in red because it's really very important. We often overlook it. And adjusting, dealing with the environment in terms of the environment's reactions to the tics, whether it's the home environment, the school environment, the work environment, etc. For a lot of patients with mild to moderate tics, this is enough. Okay, if the tics are not causing any problem, then this is all that's needed. That's the intervention. Um, but if the tics are causing problems and they need to be targeted, and as we know, tics can cause problems. They can impact function. They can cause physical pain, discomfort, even injuries. Socially, they can be very problematic. And if they need to be targeted, excuse me, the first line treatment is behavioral therapy, in particular in the form of habit reversal training. Okay, there are quite a few clinical practice guidelines out there for Tourette syndrome. They're generally all good, and there's some variability across them. However, they all agree on one thing, which is that behavioral therapy should be the first line targeted treatment for tics. If medication is required, then our mainstay treatments are the alpha-2 agonists and antipsychotics, in particular the higher potency antipsychotics. Um, and these are our mainstay treatments. There are other options, but these are the main ones. Okay. The other aspect in terms of the management of Tourette syndrome is the comorbidities I mentioned earlier. So, in particular, OCD and ADHD, anxiety, rage outbursts, and a whole slew of others. And sometimes those are more problematic than the tics themselves. Sometimes they interact with the tics, and then it takes some negotiation to figure out how best to start and etc. Okay. So this is kind of just the overview. What about the medications? Let's get into a little bit more detail there. As I mentioned, there are a number of clinical practice guidelines out there for Tourette syndrome. My favorite ones that I think are really good in terms of how they were done, how they evaluated the evidence and everything, are the American Academy of Neurology guidelines. They were led by Tamara Pringsheim, who's a neurologist in Calgary, and what they do is they make recommendations. They with different strengths. Their recommendations. Okay, they call it level, and the strengths are level A, B, and C. Level A is you must. Level B is you should, and level C is you may. Okay, this is how the recommendation. So this is in terms of how strong their recommendations are, and then they also give an assessment of the evidence for any intervention. Do they have a moderate, based on how strong the evidence they evaluated was, they might say it's low or moderate or high level of evidence. So in the case of the alpha-2 agonist medications, it's the level B recommendations, meaning they're telling clinicians you should offer this as an option to patients, okay? And the evidence there is low to moderate, remember, depending on the medication, okay? That's in terms of how good the evidence is, in terms of how good these treatments are for the tics. When it comes to the antipsychotics, there's more confidence in the evidence. It's moderate, actually, but the recommendation is a level C, meaning you may give this recommend this for patients as an option. And the reason is because the adverse effects of the antipsychotics can be quite concerning. So this is not something, at least in North America, we tend to jump to right away. In terms of adverse effects, it's level A. That's the one thing that gets a level A recommendation. You must talk to patients about the adverse effects, you must monitor them, etc., etc. So as I said, these are the two mainstay, but there's a whole slew of others and of other agents, and including, in particular, um, uh, cannabis, okay, or cannabinoids. And in particular, THC, tetrahydrocannabinol, which is one of the main active ingredients in cannabis. And specifically for adults, okay, and they give a level C recommendation, meaning you may talk about it with the patients. Their level of confidence in the evidence was low. Okay, mind you, these guidelines came out in 2019. The evidence would have been evaluated from a year before, so there's been more evidence since that I will go over with everyone today. All right, poll question. When you think about cannabis for tics, what comes to mind? It's a fad that will eventually pass. It can be helpful for some people. It is being pushed by companies that profit from it. Give a minute for people to put in their answers.
Okay, we're just going to give it a couple more seconds. Okay. So we had 100% say that it can be helpful for some people.
Wow, 100%. Okay.
Mhm. We
Well,
had
okay.
someone do a clapping emoji
All
and a
right.
heart.
Wow. Talk about consensus. That's amazing. Okay, so you are all correct, as I think it can be helpful for some people. I want to say if someone said it's a fad that will eventually pass, I think that's correct too. And what I mean by that doesn't mean pass as in disappear, but there is a fair bit of hype about it. And I hope that that will dampen a little bit because we want to be level headed and clear minded about it. And then it is being pushed by companies that profit from it. Unfortunately, that is also correct. Okay, so all of these answers are correct. But if I was stuck with choosing just one, I think I would favor the one that everyone chose, so they can add me to the consensus. It can be helpful for some people. And I'm going to start from the beginning of how I got involved in this. And as I mentioned, this was really very much driven by patients. This was really about 15 years ago. I was fresh out of my clinical training, working in a Tourette Syndrome clinic in Toronto. And I see a patient where the reason for referral was specifically for cannabis for tics. Okay, it wasn't about to evaluate is this Tourette syndrome or the management and such. It was specifically wanted cannabis for tics. That's what this patient wanted, and this was a young adult patient. And what had happened is he had been to a party, and there was a joint being passed around. Joint meaning cannabis joint, weed, and he smokes up a bit, and then he goes home, and his family was like, "You don't have any tics. Where are your tics?" And puts two and two together and realizes it was the cannabis that caused decrease in tics. And so he started using cannabis, and he found it was quite helpful for the tics, but he was getting it from the street, and he didn't want that. He wanted medical cannabis. I had very limited experience with this, really. Clinically, never used it, and personally had tried twice in my life at similar kind of parties, and I was uneasy. This was especially at the time, and I was aware that there were two small studies, and I will touch on those two small studies actually that showed some effect for tics. But I was also aware that cannabis had serious risks with it, especially for a young person, and especially for using it every day. And I started talking about the limited evidence, the risks, and that kind of thing. And the patient stops me. Just stop right there. I've gained 50 pounds on risperidone. I slept through high school on clonidine. Okay, risperidone antipsychotic, and clonidine, an alpha 2 agonist. You're not going to tell me this is worse. This is working for me. Like, don't give me your. So it was compelling, and we did it. I tried to figure out. We figured out together. At the time, it was a different process. I had to. It was an application to submit to Health Canada, etc. It was quite a process at the time, but anyhow, got the approval, and the patient started using medical cannabis. I'd never prescribed before, and it was really learning things as I went together with the patient. We were learning together. And the patient did very well on it. Went back to school while working a part time job, got a graduate degree, was in a relationship, did very well, really. And so, over time, I started hearing this more and more from patients. I'd be asking, what kind of things make the tics worse? What kind of things make the tics better? And every once in a while they'd say, yeah, I was at a party, I smoke up a bit and I realized my tics were better with cannabis. And I was hearing this story where people serendipitously, like not expecting it, especially at the time when cannabis, again, now it's very much in the air, but at the time, it's not something that people were thinking about medical cannabis as much. But this realizing it was helpful for the tics. So I started offering it even for patients all adults, for whom who had failed multiple treatments. Okay, behavioral therapy, antipsychotics, alpha 2 agonists, nothing's working, and they continue to have severe tics. So I'd say, you want to try cannabis, medical cannabis. And so we'd go there, and quite often there would be a significant improvement in the tics. So that's basically been the story. And then at some point, our groups started researching it. We figured this was something important, worth pursuing, and that's how we got into this. All right, so just a bit of a brief history of cannabis in North America, just to give us some background to contextualize everything that's happening. And it does impact what we do and what we can do, this history. So in 1913, the states of California, Maine, Wyoming, and Indiana all banned cannabis, okay, just over a century ago. And then 10 years later in Canada, cannabis was criminalized. In 1970, at the federal level in the United States, there was prohibition of cannabis. And so for most of the past century, you can see cannabis was just illegal in any shape or form. Until in 1996, California, at the forefront, legalizes medical cannabis specifically. Okay. And then 5 years later, medical cannabis is legalized in Canada. So not that long, really, just over 20 years ago. And then in 2012, Colorado and Washington were the two first states to legalize recreational cannabis. So now, no longer just medical, this was recreational cannabis being legalized. Same as, you can buy alcohol to have a drink, you could get cannabis. And then increasing number of states have followed suit. And in Canada, in 2018, so recreational cannabis was legalized across Canada. And then most recently in 2022, there was a Medical Marijuana and Cannabidiol Research Expansion Act passed at the federal level in the United States. Since, by the way, this is the New Jersey Center for Tourette Syndrome, and I think a lot of the audience is from New Jersey, I just want to say, in New Jersey, medical cannabis was legalized in 2010. Okay, so just 15 years ago. And then recreational cannabis was legalized in 2020, so 5 years ago. So what I want to, a couple of points here is that one point is this is all very recent. Okay, this is still emerging. We're still trying to figure out these out. There's a lot that we need to figure out still with regards to cannabis and medical cannabis. Excuse me. Another thing is there's a lot of variation across jurisdictions in terms of what you can do legally. Okay, so that's and what we've been able to use medically has changed dramatically over the past 15 years. It's amazing, I have to say. For example, you could use the cannabis herb could be inhaled, but you couldn't consume it orally. That was illegal in Canada. It was lots of striking things like that. And then the other thing, we're talking about cannabis, but then there was all of a sudden all these different cannabis products, trying to figure all of these things have been evolving over recent years. And then the other thing I want to say is recreational cannabis is legalized in much of the United States now and in all of Canada. And so you don't even need medical cannabis. It's available recreationally. You don't need the doctors or anything like that. But is that a good thing to be using it, to be accessing just recreational cannabis without any medical guidance? So leave that as an open question for now, and we can come back to it later. All right, hype. There's a lot of hype. There's been a slew of private cannabis clinics and companies that are marketing the products left, right, and center to everything. And these are just some flyers that I receive unsolicited. I'll show you this one as an example from one of these clinics. Commonly treated conditions: anxiety, PTSD, ADHD, depression, insomnia, stress, panic disorder, bipolar disorder, borderline personality disorder. My goodness, next thing they're going to put here is world peace. So it's when something is supposedly such a panacea for so many things, I mean, you got to be suspicious. It's really, it makes you think of snake oil, really. Like it's a good for everything kind of thing. So we have to be very careful. And indeed, this is a piece written by Ruth Ross, who used to be the chair of the pharmacology department here at the University of Toronto. Why we need to press pause on any kind of cannabis promotion. Many companies are selling marijuana as if the drug is totally harmless. It's not. Okay. We have to be very careful and remain clear-headed about this, even as promising as it is. Okay. All right. So I've cannabis. When we talk about cannabis, the plant, there are many compounds in cannabis, and there are two in particular that get a lot of attention. And one is THC, 9 delta tetrahydrocannabinol, THC, and and that's one of the main active ingredients. That's the ingredient that gives you the high when people are using smoking weed at a party kind of thing, or not just smoking, or that's consumed orally. That's what gives you the high. And what it does is it acts on two receptors in the brain, what we call they're cannabinoid receptors, and one is CBR1, CB2, cannabinoid 1 receptor and cannabinoid 2 receptor. Okay, and these receptors, they're called cannabinoid receptors because not just because THC binds on them, but because we have endogenous cannabinoids, we call them endocannabinoids in the brain that actually act on these receptors on the system. Okay, and these receptors are rich throughout the brain. In particular, like the CB1 receptor is rich in the basal ganglia, which are involved in movement and all sorts of things, including we believe in tics and Tourette syndrome. And what THC does on these receptors, it's a partial agonist. Agonist means it stimulates these receptors, but it's partial, means it doesn't stimulate them fully, it stimulates them partially. Okay, that's what THC does. Another main one is CBD cannabidiol, okay? And it acts on the same two receptors, except it does something different. It's a negative allosteric modulator. That's a mouthful. Don't worry, Katie, I won't ask you to pronounce it. But what it does is it's a modulator allosteric, means it changes the shape of the receptor. Negative meaning that it makes it less likely that agonists are going to bind to it and activate it. Okay, so it decreases the effect of THC or endogenous cannabinoids, the endocannabinoids. So these are the two that get a lot of attention in nature. In the cannabis plant, typically it's either got high THC and low CBD, or the other way around. Okay, it's not usual that they both are high. But these days with technology and whatnot, you can have all sorts of combinations. But this is relevant that I'm mentioning this. But while we focus on these two receptors, there are hundreds of other compounds, all understudied in terms of what exactly they're doing. So a lot to be figured out still. And then there are the terpenes. The terpenes are compounds that give it its distinct odor and taste, and it's felt that these have an impact in terms of the effect of the other compounds, in particular the THC and CBD. People use the term entourage effect. So the environment of these compounds will influence what kind of effect they can have. Okay. So that's cannabis. I'm going to go through now the actual products. Okay, what are the cannabinoid products that are available? And again, there's going to be variability by jurisdiction for sure. Okay, I'm going to talk about the pharmaceuticals, meaning they're cannabinoids that you can prescribe, like any medication that you prescribe. Okay, and then I'm going to talk about cannabis itself and how it can be inhaled or consumed orally. Okay, so with regard to the pharmaceuticals, there's nabilone. Nabilone is a synthetic drug that acts similar to THC, basically. It stimulates, it's a partial agonist of the CB1R and CB2R receptors, okay? So that's nabilone. And then dronabinol, it's also synthetic, but it's basically THC. It's a THC in a pill, basically. I've prescribed this a fair bit in the past, no longer because for whatever reason, it's no longer available in the market in Canada. I'm not sure why, but it is available in other markets. Okay, so these are both orally taken prescriptions. And then you have nabiximols. Okay, nabiximols is a spray that is almost equal parts THC and CBD. Okay, and it's a spray, you spray it on the inside of your mouth and inside of your cheek or under your tongue. Um, so that's another one. And then lastly, cannabidiol. Cannabidiol is consumed orally. It's basically CBD that I mentioned, and that is used primarily in epilepsy, in some rare forms of epilepsy, CBD. When it comes to cannabis itself, it can be inhaled, either smoking, the good old-fashioned way, or it can be vaporized or vaped. And there's a difference between the two, okay? Smoking is not something we recommend, although some of my patients have discovered the smoking, want to continue doing that. Vaping is one where people hear a lot about. Vaping is one where there's a cartridge with a liquid in it, and then the product is in that liquid, and that's heated up. That's how you vape it. But then there's the chemicals from the liquid and whatnot. If the person prefers to inhale, the favorite would be vaporizing. I think it would be the least harmful, where it's the herb itself that is warmed up in a vaporizer releasing the compounds. Okay, that's for inhaled cannabis. And then for oral cannabis, it's the oil is, I think, what we're using most commonly these days. So the compounds are activated and made into an oil, or it can be capsules or edibles. The famous cookies people talk about. There are other forms as well, like drinks and such. It's not something that I go through. It's mostly in the recreational realm. All right. I've been saying quite a bit, actually. I'm going to pause just for a sec. Everyone with me? Any concerns? Is that too fast, or are we good? Thumbs up if we're good. Thumbs down if I should slow down or do something different.
You're getting a whole bunch of thumbs up, so you're doing good.
Okay. Okay, great. Wonderful. All right. What are the effects? So first, the benefits. So these compounds have been used, in particular pharmaceuticals, as antiemetics, so anti-nausea, especially when for people undergoing chemotherapy for cancer and they have a lot of nausea. For appetite stimulation, same with the chemotherapy for cancer or with AIDS. They can be helpful for pain. They can be helpful for spasms and multiple sclerosis. And CBD in particular can be helpful for certain rare forms of epilepsy. And I emphasize that because there's all this excitement about CBD. Unfortunately, it gets so much hype in the wellness industry that I've seen. It's amazing how the landscape has changed, where I've seen patients or parents giving their kids like 5 drops of CBD oil a day because they have Tourette syndrome and there's some concept that it's good for you. And no, don't do that. None of this is benign. Unless you have these rare forms of epilepsy where it can be miraculous, actually, it is quite striking, but it's very particular use. So this is what we know so far in terms of the potential benefits. What about the harms? The list is much longer, and maybe this should not be surprising. I would say this is the case for pretty much any treatment, any of our at least medication, pharmaceutical interventions. And it's a long list. This is not an exhaustive list, but I'm telling you, I'm going to go through it quickly. These are not uncommon things, and pretty much all of these things I have seen clinically. Okay, dizziness can cause dizziness, sedation, fatigue, psychomotor slowing, this feeling of high, and I'm listing it under harms because patients who are taking it to help them, let's say to help their tics, they don't want the high. They don't want to be feeling high, so it's really a side effect. Amotivation, depression, irritability, anxiety, a feeling of derealization, depersonalization, things feeling odd, unreal, altered perception, psychosis, dry mouth, and red eyes. Okay, so these are things to be aware of. Doesn't mean they will happen, but these are side effects and they're not rare. Okay. All right, what is the evidence? The evidence. As I said, there's different kinds of evidence, and I'm going to go through retrospective studies, open label studies, and then finally the double-blind randomized controlled trials. The retrospective studies are basically mainly you take a bunch of people, you look for a bunch of people who are using cannabis in your clinic, and you ask them, okay, how's it going? Is this helping? And then you report what they share with you. So these are the retrospective studies. As you might guess, they're more likely to be positive. That's why these patients are taking them, right? And there's going to be bias in what they remember and all of that. Okay, so these are the retrospective studies. And a lot of the studies are retrospective. I'll nevertheless go there. It's worth going through them together. Open label studies are basically studies where you give the patient, okay, it's not going to be just retrospective. I'm going to, the next 20 patients, I'm going to give them cannabis. Maybe not all the next 20, but I'll choose them carefully and I'm going to give them and I'm going to follow them and see what happens. Okay, so in a way, they're less biased. You're following the patients longitudinally, but they're open and they know that they're getting the cannabis. There could be the placebo effect. There's no control, right? They're not comparison to any other intervention. So maybe the tics were going to get better anyway. We know tics fluctuate. So these are the open label studies. So the gold standard really are the double-blind randomized controlled trials. Okay, so there could be a placebo comparator and people are randomly assigned. It's not like you're choosing through some bias, not necessarily in a negative way, but it could influence the results. who gets what. It's randomized and it's double blind. You don't know who's getting what. Patients don't know who's getting what, or at least so we think. And so these are considered the gold standard. We'll look at the evidence from such trials as well, and we'll see how the results are going to be different based on the kind of studies. Let's start with the retrospective. Okay, there's quite a few here, but don't worry, we'll walk through them quickly, and it's not so much the specifics of each study is not what matters. We want an overall picture. So the landmark study, the original pioneer study, was done by Kirsten Muller-Wahl. I mentioned her name. I won't be mentioning all the names, but her in particular, she's a neurologist in Hanover in Germany, and she's really been a pioneer in this area, and you'll see her name over and over. This was published in 1998, so quite a while ago now. And she asked a series of patients if they've ever tried cannabis. And from all the patients she asked, 17 said they had. And of these 17, 14 said that they found that it decreases tics and related symptoms. So 14 out of the 17 that tried it. Okay, not bad. We did a study much later that we published a few years ago now, again, retrospective, where we asked the 18 patients we identified who agreed to participate, and 17 of the 18 patients who participated were rated as either very much improved or much improved clinically. And we looked at other things as well, and we found generally other symptoms tended to be better as well. This one is a bit of a better design because they asked a whole bunch of patients who had tried cannabis, who had been prescribed cannabis, and not just the ones who are still on it. And 38 out of 48 patients reported any kind of benefit. Okay, still a fair, good amount. I want to say that 10 stopped it, so that's important to know, and for different reasons, including side effects. And there's mentioned that 1 developed psychosis, acute psychosis, and 4 developed hallucinations. So this is, not insignificant. Next, this study, larger than all the others, 98 patients, is again from Kirsten Muller-Wahl's group in Germany. And they asked them about different types of cannabis they tried and preferences and such. And interestingly, there was a strong preference for THC-rich medical cannabis in comparison to stuff that was not rich with THC or in comparison to the pharmaceuticals. And then lastly, the study, out of 25 patients, they found 75% reduction in tics. And they also found that there tends to be an increased dose over time. Like they followed the patients for several years, and basically there was suggestion that maybe over time they were requiring more. Okay. All right, so this is the overall of the retrospective, and it looks pretty positive. One thing I want to highlight here is of all of this is mostly in adults. There are only 7 cases reported in the pediatric age, okay? So all of this work being done in the adults. What about the open label trials? And I'm mindful of the time. I'm going to speed up a tiny bit here. The open label trials, there are 2, and basically one, you see they're not large trials, 16 adults, 18 adults, open label THC, 10 milligrams. And this is, they added this chemical palmitoyl ethanolamide, the idea that this has a kind of entourage effect that can enhance the THC effect. Anyhow, they found a 20% improvement based on the YGTSS total tic score. YGTSS is the Yale Global Tic Severity Scale. It's like the gold standard for measuring tic severity. And the total tic score from the scale was 20% improvement. And in this other trial, it was oral. Well, actually, it was not just oral. They used it in different ways. The average dose was about 0.6 grams a day, 38% improvement in YGTSS. Right away, you can see from these 2 studies, the effects are not as big. There's effects, but they're not as big as what we see in the retrospective. What about the randomized clinical trials? Well, here's what we see. So first of all, Kirsten Muller-Wahl did the first study back in 2002. This was a single dose crossover trial of oral THC versus placebo, and there was an effect, a significant effect in favor of the THC versus the placebo. Okay. But this was single doses. Okay, she then followed suit and did an actual ongoing treatment study. It was a 6 weeks randomized control trial, THC versus placebo. Again, it was favorable for the THC, but the effects were inconsistent, not at all time points, not so clear cut. And notice when both of these were published over 20 years ago, and then there was a big gap. There was very little done in the meantime. She then did another study, more recently published this in 2021. And this one used something different. It's not cannabis. It's a compound that inhibits the enzyme that breaks down the endogenous cannabinoids, the endocannabinoids. Okay, so the idea that if you're breaking them down less, then you have more endogenous cannabinoids and you have more transmission in the cannabinoid system. However, this study was significant in favor of placebo. So the placebo arm did better than the drug arm. Okay, I was hesitant, to be honest, whether to show this one or not, because it's really not actual cannabis, but nevertheless, there you have it. This is one of the RCTs that was done. And then there were 3 other RCTs, and those I'm going to show in a little bit more detail. Okay, one from Kirsten Muller-Val, again, I told you, so her name keeps coming up, one from us, and one from a group in Australia. And I think we can learn from each one of these. The one from Kirsten Muller-Val in Germany, 97 patients were randomized to either get nabiximols or placebo. Nabiximols, if you remember, is the spray where you have almost equal amounts THC and CBD, okay? And they were randomized in a 2-to-1 fashion, meaning more patients were randomly assigned to get nabiximols than placebo, twice as many. And they used between 1 and 12 puffs a day, okay, maximum 32 milligrams of THC it came to, which is not an insignificant amount, and they could adjust this dose based on how to get benefit and to avoid side effects. Okay, there was during 4 weeks was when the dose was adjusted. Once it was adjusted, they stayed on a stable dose for 9 weeks for a total of 13 weeks. Okay, and this is what she found. The red arm is the placebo, the red line is placebo, and the blue is the nabiximols arm. Okay, and you can see that there's a reduction in both of them. There's a reduction. Okay, here they go back up because here they stopped the treatment. They had a follow-up after. Okay, you can see there's a reduction in both cases, and you can see that the reduction in the nabiximols arm is larger. However, it did not statistically separate from from each other. So statistically, it was not significant. It was negative. But the other thing is, regardless of the statistical significance, if you look at the amount of change, the degree of change, it's not huge, really. Like if you look at the YGTSS total tic score, like the difference between placebo and the nabiximols is like 2 points on the scale. So not a huge effect. 95% reported at least one adverse effect. Okay. Now, almost all were mild, so there was only 1 or 2 serious adverse effects. But they don't go into details of describing what exactly those were, but anyhow, they describe them as pretty much all mild, but still the majority experienced something that was adverse effect. Next poll question. Which component of cannabis do you believe will decrease tics the most? THC, CBD, either THC or CBD, neither THC nor CBD. So Katie,
Okay, we're going to let it go
yeah.
for a couple more seconds. Okay. So it looks like THC won with 63%, CBD had 21%, and then either THC or CBD had 17%.
Okay, okay. Not a clear-cut consensus like before, but the majority is thinking THC. Interesting, interesting. All right. So I think we have clues from the studies that I just went over, including the retrospective. But this is the study we did was precisely to answer this question. Okay. It was a single dose trial, crossover of vaporized cannabis. Okay. Crossover meaning each participant got a quarter of a gram of either THC or a combo of THC CBD or CBD or placebo, okay, in a double-blind fashion. And what did we find? Well, these are I'm going to show you these results. So the modified Rush video tic rating scale. So this is where you take a video of the patient and then you rate someone who's completely not involved directly, rates the tics they see. What did we see? The turquoise color is the THC arm. And you can see a signal here that the tics go down with this one, okay, with the cannabis. The red is the placebo, and then the other two are the other colors. And this was not statistically significant. It did not separate, okay, here. But we also looked at the premonitory urge for tic scale and the subjective units of distress scale. And you can see here a clear effect of the THC arm. Here as well, clear effect of THC arm, very significant in both cases, and nothing from not the case for the others. The other thing that's interesting, and this is, sorry, it's a bit of a crowded slide, but don't worry, I'll just point out the main things, is we got the blood levels of the cannabinoids and their metabolites. And what we found is that for the THC, there was a clear correlation with regards to what you saw, including on the video tic rating scale, where the higher the level of, in particular, hydroxy THC, which is the main active metabolite of THC, okay, when it gets broken down, it's the main activity comes from high. And so the higher that was, the lower the tics were, lower the PUT scores were, and the lower the subjective units of distress scores, okay? Whereas in the CBD, there was no correlation whatsoever. It doesn't matter what your blood level of CBD was, it did not impact your tics in any way, shape, or form. Okay. So the point being here, if there's any positive effect, it's against the tics, it seems to be coming from the THC really, and really nothing from the CBD, based on the blood levels and the earlier slide that I showed you. The other thing, though, is there's no free lunch. The adverse effects were coming mainly from the THC as well. And this is the total adverse effects. Again, the turquoise is the THC, and you can see it was much higher than the other two arms. And here's the placebo. It's the one that had the least adverse effects. And most of them coming from cognitive effects. Okay, so not benign. And then lastly, I'm going to quickly go over the Australian study. So the Australian study, they had 22 patients, each got a combo of equal amounts of THC and CBD versus placebo as the comparator. Okay, they dosed it over 4 weeks, and then and this was a crossover trial, meaning that they took one either placebo or cannabis for 6 weeks. Then there was a 4-week washout. Then they took the other for 6 weeks. What was the result? This is a bit of a crowded slide, but don't worry. I'll walk you through it, and it's really neat actually how they present it. The dots are the symptoms of the patients. Each one is an individual participant. Okay, in green it's the cannabis, in yellow it's the placebo. Okay, and these are the scores based on the YGTSS total tic score, and you can see they're pretty much overlapping the individual, and these are the averages for the placebo and for the cannabis. And what they show is at 2 weeks, at 4 weeks, and at 6 weeks, over time, what happens is they start to separate. And the placebo is not going down as much, but the cannabis arm is going down, okay? And you can see by the end, a clear separation between the cannabis and the placebo. They also did it for the global score of the YGTSS, where they add the impairment scale as well, clear cut separation. And they also did the video tic rating scale, clear separation. So this was a fairly positive study showing an effect of the cannabis compared to the placebo. In terms of, they also did blood levels and did correlations, and their results, I'm not going to go through these graphs because of time, but suffice it to say that the results are very similar to what we found. There were correlations with the THC, but not with the CBD. Okay. And then similarly, you have way more adverse effects in the THC arm compared to, in the cannabis arm compared to the placebo arm, including in particular cognitive difficulties. 40% had cognitive difficulties in the cannabis arm versus 9.5% the placebo. Okay. All right. In practice, so we're coming close to the end now, but I want to talk about in practice what can be done here before we go to the Q&A. So I mentioned the American Academy of Neurology guidelines. Okay, so what do they say? They say that for adults, you may offer THC if they are treatment resistant, meaning that they've tried all the treatments, the main treatments, and it's not working. They continue having significant symptoms. You may offer cannabis, or if they're already using cannabis themselves efficiently, it's good to offer them. You can offer to the medical. They also say you must provide medical supervision. You must use the lowest dose possible. so it's while still having an effect. You must periodically reevaluate the need, the need to continue. You must advise them against about driving and the risks to driving when using cannabis. Okay. Coming back to the cannabinoid products I mentioned before. Okay. Often when I will explain all of these to patients, I say in general, people tend to have more effect on cannabis itself compared to the pharmaceuticals, but it's not uncommon that patients don't want to go to cannabis right away and want to try the pharmaceuticals. And I think those can be tried for tics. Any of these can be tried, not CBD. I would not recommend cannabidiol. I think it does nothing for tics. The nabiximols, the spray I mentioned, this was a negative study from Kirsten Muller-Weil, and it's quite expensive. And from what I've heard from patients, it tastes quite awful. So we're left with nabilone or dronabinol. Dronabinol, if it's available in your jurisdiction, otherwise it's nabilone, which is what I've used here in Canada more recently. The inhaled, I don't recommend. Why not spare your lungs? But I will acknowledge there's an advantage because you feel what patients like is you get the effect immediately and you can titrate very easily to not get adverse effects or to get the beneficial effect. But also the effect doesn't last as long. Okay, so I do not recommend that, but I will acknowledge there are some patients that prefer it nevertheless. When it comes to oral, I tend to go with the oils. They very easy to titrate. It's like any prescription, and I start low and go slow. I would start with something like, depending on if the patient has prior exposure to cannabis, what's their, they might have some tolerance or not, but I generally prefer to start low. It could be as low as 1 milligram of THC equivalent taken at night, and then you can take it, and then you gradually increase it by, could be as little as 1 milligram a week, at least a week to see the effect, and in divided doses, twice a day, sometimes 3 times a day. Okay, and so it's basically like a prescription, but you're giving guidance to the patient in terms of how much to use and how fast. Some notes of caution. We don't want to forget about the harms. Okay, this is not just we want to think these are not like any prescription really. There can be risks. Want to think about the functional impact. How much are the tics affecting their function? How much is the treatment affecting their function? There are risks, in particular psychosis and mania, and these are age related, so particularly concerned with younger patients. This is more for the physicians to be aware that there can be interactions with other drugs. Cannabis is broken down by these enzymes in the liver, so any drugs that inhibits these enzymes will interfere with the effect of cannabis. I generally recommend against smoking it because of the risk to the lungs. The driving is a complex issue, and we need to give caution about that. And I'm happy to get into more questions about it. People want the legalities will vary a lot by jurisdiction. And for example, and then traveling can be an issue. So for example, it's legal in Canada, but you can't travel with it. So if people are using it, it's working for them, but they want to go away on vacation, you cannot. You cannot, even no doctor's prescription or anything. It's simply illegal to cross borders with it. And then so just in conclusion, we think not just about the impact is coming from the THC. I think everything is pointing that's where the benefit for tics is coming from, but that's also where most of the harms are coming from. The CBD, there's no point. There's no clear anti-tic effect. All the evidence is consistent with that. We need to really proceed very cautiously. The evidence is still emerging. We need to have a collaborative relationship between the clinicians and the patients. And at this point, it's almost entirely in adults. I will say I have a very few pediatric patients on it when things have been really stuck. But at this point, this should be a really last resort in this population. And I think that's it. And I'm happy for us to go into Q&A.
Thank you so much. I know it's 7:50. No, that's okay. I know it's 7:55 right now. So we're going to hop into Q&A. We might go a little bit over 8 o'clock. If that's okay with everybody, just give me a thumbs up. Okay, awesome. Thank you, guys. So thank you so much, Dr. Abi-Jaoude. Now we're going to hop into Q&A. First, I'll ask the submitted questions, and then we'll switch over to the verbal Q&A, which is when we will stop the recording. So our first question is, you indicated that tics drop with age, but not always. My 26-year-old son's tics have increased as he has aged. When that happens, what does that imply?
You know, I'm wary to give an answer that is kind of like um, definitive because we don't know. There's a lot of variability from person to person, life circumstances and such. But overall, it implies that likely they will not improve on their own. Okay, most of the improvement, if it happens, will happen during over the course of adolescence. So if you're an adult by this point, you're in your mid 20s, and the tics are where they are, they're likely roughly going to be where they are. But what I will say though is often when I see adults and I'm getting their history, often they're tying the tics to what's happening in their lives. So for example, if they're in a very common situation, they'll say, "Oh, I was in this very stressful work environment, and then when I say just change jobs, a much better workplace, things were better." I'm not saying your son should change jobs or anything like that, but just to say that the tics can nevertheless be responsive to circumstances, not always. But and then even if they are not, and the tics are still significant, how significant are they? Are they really impairing his life? If they're not, then he just has tics. That's fine. It's having tics has no implications in and of themselves. It's they can, but if they are impacting him, there are treatments available, and I hope you can find a treatment that can be helpful.
Thank you so much. And another question that we have before we hop into um, the verbal Q&A is there a specific type of cannabis that helps but does not give a high? I recall a CNN special where a young woman had seizures who benefited from low THC without a high.
Oh, I mean, first of all, I'm surprised that THC for the seizures, really the two seizure conditions, which are Lennox-Gastaut syndrome and Dravet syndrome, it's CBD, it's high dose CBD, and that shouldn't give you a high. It can have its own side effects, but that shouldn't. But nevertheless, I don't know everything, and there could be such a situation. You mentioned low dose THC. Well, the key there is in what you said, the low dose. The high is very much dose related. So if it's low dose, you're much less likely to get a high. The other thing is the high comes from the peak. You're less likely to get a high if you're consuming it orally versus if you're inhaling. If you're inhaling, goes to the lungs and then straight to the brain, there's going to be a peak, so more likely the high. But if you're taking it orally, it goes, you have to wait, it goes through your stomach to your intestines, and it's absorbed slowly, goes to the liver, some breakdown, and it rises more slowly and much less likely to cause a high that way. But it's not foolproof. People might still experience some kind of cognitive effects, but it's really very much dose related. So the lower the dose, the less likely the high.
So thank you. So before we switch to verbal questions, for those watching the recorded version, thank you so much for attending. Please complete the exit survey. An archive recording of this webinar will be posted to our website, njcts.org, under the Programs tab. The blog is now open and accessible under the archived webinar. All questions submitted during the recorded viewing will be posted there. Our presenter will be answering all questions posted until Tuesday, February 4th. Any personal information will not be included. Our next presentation will be game-based CBT for child abuse and trauma, presented by Dr. Justin Miserel. It's scheduled for Wednesday, February 26th at 7 p.m., with the recording the following day, Thursday, February 27th at 2 p.m. We offer professional development certifications for school professionals and school nurses that attend the live or recording of the webinar. To register for either time, please visit njcts.org/webinars. And with that, I'm going to stop the recording.